It is my privilege, though, at this time, to introduce our keynote speaker. Dr. Lola Fayanju is the Helen O. Dickens Presidential Associate Professor at the Perelman School of Medicine at the University of Pennsylvania, and she is the Chief of the Division of Breast Surgery for the University of Pennsylvania Health System, AKA Penn Medicine. She is also the Surgical Director of the Rainer Wowen Breast Center and the Abramson Cancer Center. She is Director of the Health Equity Innovation at the Penn Center for Cancer Care Innovation and a Senior Fellow in the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Dr. Lola, as she affectionately likes to be called, is an academic breast surgical oncologist, and her research focuses on redressing health disparities, improving prognostication and management of aggressive breast cancer variants, generating value in oncology, particularly through collecting and applying patient-reported outcomes and promoting diversity and inclusion in healthcare and research. She received her undergraduate degree in history and science and a Master of Arts in comparative literature from Harvard. She received her MD and Master's in Population Health Sciences from Washington University in St. Louis, where she also completed her residency in general surgery. She then completed a fellowship in breast surgical oncology at the University of Texas MD Anderson Cancer Center. In 2019, Dr. Lola was recognized by the National Academy of Medicine as an emerging leader in health and medicine scholar. Her research is supported by funding from the NIH, and she has published in too numerous to list, peer-reviewed journals, including the Annals of Surgery, Cancer, and the Journal of the American Medical Association. She is an advocate, she is a friend, she is a consummate surgeon and leader in this work. If this work is a symphony, Dr. Lola is our conductor. She is setting the tone, setting the occasion, and bringing us some solutions and action items that we can all take away from here. And it is without further ado, and it is my pleasure to introduce my friend and my sister, Dr. Lola Fayanju.
So I need to make sure Dr. Gary introduces me for everything. She is the quintessential get it girl, and I will always be grateful to her for that. So it is my pleasure and my privilege to be here today. I'm Lola Fayanju, and thank you so much for having me at the inaugural, because I'm sure this is the first of many, Women Speak Symposium. So the title of my talk, Moving the Needle on Disparities in Breast Cancer, has an important coda because it's what brings us all here today. What is the role that clinical trials can play in helping us redress the disparities that exist in this country and indeed across the world with regards to outcomes in breast cancer? I have some disclosures. First, it's the funding that has allowed me to do a lot of the research that I hope will make us have some actionable change in this area. And the next is my goal, which really infuses all of my work as a researcher, as a clinician, as an educator, as a mother, as a sister, as a daughter, as a woman. My goal is to elevate care for all women with breast cancer to a level that is universally equitable, effective, and efficient. In order to do so, though, we all need to have the same language and the same understanding of what's at stake. A lot of people heard the words disparity and equity used, particularly in the past few years with regards to the COVID-19 pandemic, in which we saw that America, although the land of the free, is not the land of the equal. Disparity and equity are words that are used often but not always understood. So disparity, it's an observed intergroup difference in health screening, outcomes, and/or treatment. And the idea of disparity is it's not just a difference in how people experience healthcare or receive treatment or have outcomes. It's a difference that is avoidable. It's a difference that's rooted in inequity. It's a difference rooted in what's wrong, and ideally is something that we should be committed to fixing. In contrast, health equity is the idea that healthcare and access to care is distributed according to clinical need and not according to privilege. It is the idea that equal opportunities to use healthcare resources should be available to all people. Again, if you think about disparity and equity as being opposite sides of the same coin, you would think that disparity is something that should be avoided, while equity should be the goal for everyone. But in order for us to have this as a common goal, we also need to have a common view of justice. And sadly, that is not something we are all unified about in the United States. And that is something we all need to also focus our efforts on trying to persuade our colleagues and also believing. We're in company here of people who all know this. We know that breast cancer is the most common non-cutaneous cancer in women in the United States, and that 1 in 8 women will be diagnosed with breast cancer in her lifetime. and that there are over 250,000 new cases diagnosed in the United States every year of invasive disease and about 60,000 new cases of DCIS every year. And a leading risk factor is simply being a woman. But we know that men can get breast cancer too, and as evidenced by the father of multi-hyphenate Beyonce, Matthew Knowles, breast cancer is something that can affect men, often who don't know about it until they've actually been diagnosed. Most women who get breast cancer have no family history. And first-degree relatives, however, do have an increased risk of getting it. And so it's important for you to know your history, to know that my mother didn't just die of a woman's cancer. What was that woman's cancer? Was it breast cancer? Was it cervical cancer? Was it ovarian cancer? Was it uterine cancer? Knowledge is power, and if we don't know of our history, we can't fix our future. It's also important to know that about 5 to 10% of breast cancers are genetic. And unfortunately, rates of genetic testing are lower in communities of color than they are in white communities, which means a lot of women don't know that they're at elevated risk for breast cancer and therefore might need to engage in both screening as well as preventative measures earlier than the average person. The 5-year overall survival for breast cancer is really high. The thing is, breast cancer is often seen as one of the success stories in American cancer medicine and in oncology in general because it's so evidence-based. We use clinical trials. We really have one of the kind of most peerless approaches to care compared to almost any other type of cancer in the world. And yet that's what makes many of our disparities all the more egregious. We know that white women have higher rates of being diagnosed with breast cancer, but black women are more likely to be diagnosed below the age of 40, that is before the age at which screening typically begins. We're also more likely to die at every age of diagnosis and every stage of diagnosis. Latinos are more likely to be diagnosed with locally advanced disease, that is disease that has already progressed to the lymph nodes underneath the arm, thereby requiring either radiation or actually lymph node dissections and having to suffer through the sequelae, including lymphedema, that often are experienced by people who have to have that more aggressive treatment. And because they're often diagnosed at a younger age compared to others, it means they also have a longer period of time over which they need to live with that sequelae and pursue employment while having been hampered by those side effects. And finally, as relevant to much of our talk today about metastatic breast cancer, black women are more likely to be diagnosed with metastatic disease when they're first presenting with breast cancer than other groups. And below are some of the risk factors associated with breast cancer, which are also disparate in different communities and can perhaps be contributing to why we see different rates of breast cancer diagnosis in terms of late stage and more aggressive disease across different groups. Now, the problem with a lot of the talk about disparities in breast cancer, which is a major focus of my research, is that much of the conversation over the past, I would say 20 or 30 years, is focused on things we cannot change. That is race, ethnicity, whether or not you've had children. We know that rates of breast cancer can be higher among women who are in the LGBTQ community. But these are things that we can't change, nor should we be focusing on simply cataloging all the ways in which certain groups are affected more than others. We've had much less successful translation of the knowledge we've acquired into actual outcomes-oriented interventions. And so what are we going to do about it? And one obvious place in which we can make a difference is with regards to clinical trials. But that is not as easy as we would like to think. In 1993, Congress, in a bygone episode of bipartisan collaboration, passed the NIH Revitalization Act, which was focused on actually trying to increase women's and minoritized groups' participation in clinical trials. And the idea was that if we could really focus on making sure that women as well as people of color were more involved in clinical trials, again, this was happening 30 years ago, okay, then maybe we could do a better job at improving what we know are already abysmal rates of participation. Now, about 5 years ago, a group from the Mayo Clinic conducted a review to see whether or not this trial had actually, or this act had actually made any kind of difference. And what they found was that unfortunately, racial and ethnic minority groups still remain disproportionately underrepresented in all of these trials. But they did find that breast cancer seemed to be an exception. That amongst breast cancer trials, there seemed to be close to something like racial parity. And so the question is there something special about breast cancer? Is it because of the advocacy that happens in our community that maybe we're closer to some kind of ideal that remains elusive for other groups? Now, I'm a surgeon, and I noted that this particular study did not include surgical trials. That is, trials that actually looked at whether surgery was the focus of intervention being studied, or if surgery was a criterion for inclusion. And so we then conducted a review specifically looking at surgical oncology trials in breast cancer to see whether the parity that was observed in these other trials since the passage of this act was also seen in breast surgical oncology trials. And so we conducted a retrospective cohort review comparing women in the National Cancer Database, which is a hospital-based registry database that includes about 70% of all breast cancers in the United States, and that includes all the cancers diagnosed through the Commission on Cancer accredited hospitals in the United States. And we compared them to actual trial participants in the Cancer Therapeutic Evaluation Program. That is, we compared people who actually underwent or participated in breast surgical oncology trials to those who, by virtue of their criteria, were potentially eligible. That is, we wanted to get a sense of how good a job did we actually do at getting people who could have been in breast cancer trials for surgery into those trials. We wanted to see how good a job we did, what factors were not associated with actually participating, and whether there were actually differences between the races. And what we found was that, interestingly, participation across all racial ethnic groups had decreased over time. And that wasn't because there hasn't been enthusiasm for clinical trials, but it's because the nature of clinical trials has changed tremendously. In the past, when you think about the big NSABP trials, we were looking for, do you have cancer? Come be in our trial. We weren't worried about whether you're triple negative, because we didn't know what that was. We weren't worried about whether you were PD-L1 expressing, because we didn't know what that was. So the opportunity to participate in a trial was much greater because your eligibility was much broader. As our trials have become more biomarker and biotype specific, we're looking at threading a more narrow and narrow needle hole, which means that we have to be even more thoughtful and intentional in terms of who we're recruiting into our trials, regardless of racial background. So that means that the opportunity to participate is becoming harder and more diminished for all people. That's one of the first things we found. We also found that, yes, unfortunately, Black and Hispanic women were still less likely to participate than white patients in these trials. But what we found was interesting interactions between race, ethnicity, and income. We actually found that high-income Black women were less likely to participate than low-income Black women. And the reason this is important is because, as you can imagine, often when there are conversations about clinical trial participation, people try to elide racial and ethnic background with socioeconomic status, when they are not the same thing. One of the things we've really had to focus on, as people have been increasingly drawing attention to social determinants of health and unequal outcomes after COVID-19, is that social determinants of health does not equal racism, and that you can be a very well-resourced Black person and still be treated poorly and experience untoward outcomes as a result of that. And so it's going to be very important to realize that we have to have multifaceted approaches to improving both clinical trial participation as well as outcomes in diverse groups. So in conclusion, what we realized is that differences in trial participation parallel complex interactions, not only across racial and ethnic groups, but within racial and ethnic groups. That we need to understand the diversity within Black populations, Latina populations, Asian populations, Native American populations. And we'll need a diverse array of interventions to facilitate equitable trial participation. Throwing money at the situation and offering quote unquote resources is not enough. We need to understand what really motivates people to participate or to avoid clinical trials. In addition, we need to really be specific and intentional, because future trials are going to be ever increasingly biology driven and subtype specific and clinician informed. And it is at our peril not to over-enroll the minority patients who we know are often diagnosed at higher rates with, for example, triple negative breast cancer in terms of women of African descent, or HER2-enriched breast cancer in terms of women who are Asian, because we lose the opportunity to better understand the pathophysiology of those particular subtypes in groups in which they are overexpressed. We have seen this lesson learned with regards to prostate cancer, where trials that have over-enrolled African-American men who have higher rates of castration-resistant prostate cancer have allowed for us to understand better the pathophysiology of prostate cancer and the role that certain types of SNPs, or single nucleotide polymorphisms, have played in more aggressive types of breast cancer. That knowledge has elucidated the understanding of that disease for all men and improved the understanding of prostate cancer for all men. And a similar lesson could happen in breast cancer. So again, the reasons to improve diversity in clinical trials not only affects diverse patients, it affects everyone. But the problem is, we can't achieve clinical trial diversity unless we have people at the table who think it's important, people who at the table who want to fund these trials, investigators who want to design the trials to have these people included. But who is at the table when these decisions are being made? I would argue not enough of the right people. Now, one of the challenges is convincing people that there's even a problem, believe it or not, in health disparities and research. We know that, for instance, with regards to clinical trials, African Americans represent about 13% of the US population, but only about 5% of those who participate in clinical trials. Likewise, we know that Latinos represent about 15-20% of the US population, but only about 7-8% of those who participate in clinical trials. But what really is concerning is that underrepresentation in clinical trials occurs even in cancers that have a higher prevalence in people of color, such as multiple myeloma. We also know that African Americans and Latinos are actually overrepresented in phase 1 trials, but underrepresented in phase 3 trials. So again, I know that we're in an experienced crowd here, but to clarify, phase 1 trials are first-in-human trials. These are trials that are for the first time making their debut in a human being outside of an animal model, which means they are high risk and ultimately of relatively low benefit to the individual, because we're really just testing safety. We're testing to make sure this isn't going to hurt a human when we put it in them. And so the patients who typically get this are either healthy volunteers getting something in a very low dose, or people with very advanced disease, for whom this is really the case that, you know what, they're so close to death's door that honestly, it's not likely to cause them much more harm. In contrast, a phase 3 trial is the opportunity where you might be getting the cancer drug that is going to save your life. And so phase 3 trials are the ones that represent those that are the most vetted, that have been through phase 1 and phase 2 trials, where we are at the point of testing a new intervention versus standard of care, and therefore there is the least harm potential to the subject or the participant, and the greatest possibility of individual benefit. And so when we see that African Americans and Latinos are overrepresented in the trials that have the greatest potential for individual harm and the least potential for personal benefit, but underrepresented in the trials that have the greatest potential for harm and the least potential for individual benefit, we have to think really hard about what our consent process and recruitment looks like. We also know that phase 2 trials are the ones that are going to be looked at closely for FDA approval and for marketing. And so these are also the ones that have very strict inclusion and exclusion criteria. We exclude people who have high rates of comorbidity, who have conditions that we know are more common in communities of color, like diabetes or high blood pressure. But they're precisely also the conditions we need to know if patients have, because if they have them and they also take these drugs, they may not be able to complete those treatments. They may have side effects that we won't see until long beyond these drugs being approved. And so what is the point of having drugs that we prove are quote unquote efficacious if they are not ultimately effective in the communities that we need to see them being used in? And then finally, we also know that Black patients are more likely to participate in trials that do not require informed consent. That is, trials that are done in the emergency setting. So for example, emergency blood use products, for example. We know trials that in which there is a potential risk to the patient, we see higher use, we see higher representation of people of color. And again, it makes us really think about what our recruitment and consent processes look like. Are we exploiting a therapeutic misconception of our patients? Are we failing to convey the goals and the risks of phase 1 and phase 3 studies? And are we engaging in enrollment bias in phase 3 studies in order to get the types of numbers we know will get us to approval? We need a framework for better science. And that framework begins by changing the players. We need diversity in terms of who is actually doing the research. This research and this diversity, this begins at design, deployment, and dissemination. Whether you're a researcher, you're a patient advocate, you're a funding agency, you need to think about who your collaborators are and how you complement each other. What do all of you bring to the table, and how can you enhance the mission of the work you're doing? Who are your statisticians? They are not just there to collect p-values. These are people who can help you really think about how you can enrich your sample in order to get patients who, ideally, can be overrepresented for the purpose of making sure you don't miss out on those patients who are more likely to have aggressive forms of cancer that have so far been underrepresented in a lot of clinical trials. Who is doing your recruiting and your counseling? Who are those people, because they are your gatekeepers? How are you incentivizing participants with regards to reimbursement, with regards to the site of care, with regards to how frequently they need to come in? And are you in danger of conflating race and genetic ancestry when you do your work? This language is really, really important. And patients are more savvy than you think. They want to know that you understand that race is a social construct, but that just because it's a social construct doesn't mean it's real, because it is. And then finally, who represents the future of your research? And where are they right now? And this takes me to a point of my research that actually seems a little bit far removed from breast cancer, but it's really important to me, namely, how do we improve diversity in medicine and healthcare? And I've worked with a wonderful team of medical students and residents to actually do increasing amounts of work understanding how we not only get people into the pipeline for research in medicine, but how we keep them there. The truth of the matter is we have people who now want to go into medicine. It's not that for lack of seeing people like Dr. Gary and me that people can't know that doctors can look like us. But how do we make them stay on the path? How do we keep them engaged? How do we not have them fall off the tracks and dissuaded from believing that this future can be theirs? What we found is that, unfortunately, if there are not diverse faculty at medical schools, we will not have diverse students come through them. We did a research study looking at AAMC medical schools between 2011 and 2019. What we found is that when there are more underrepresented medicine faculty in a program, we have more female medical students of all races, as well as more underrepresented medicine medical students. But just having more female faculty alone was not enough. And the reason I mention this is because, frankly, having more women is the first or the lowest hanging fruit on the DEI tree. And that is something that has been easier, I think, for American society to embrace because everyone knows a woman and everyone has a mother. But the truth of the matter is it's been a lot harder to move the needle with regards to race, and it remains so. And that's something we need to look in the face. In conclusion, when we really focus on improving the racial and ethnic diversity of, especially of underrepresented in medicine, faculty, it represents that an institution is really committed to making a change in DEI, and it also means that those faculty often bring everyone to the table. They make everyone who feels unseen and unheard in medicine feel seen and heard, and it means that medicine becomes a more diverse, representative place. So if you have an institution that remains stagnant at the faculty level, it drags everything down and slows everything up. So this is really, really important, and I bring this up as an aside only because the extent to which we as a community can make sure our researchers and our students and our trainees look diverse, that is ultimately going to have an impact on the kind of excellent research we can do. So as I said, we got to change the players. But we also, in conclusion, need to change the game. Thus far, the focus of our research has been a bench-to-bedside model. That is, we have scientists, of which I would consider myself one, sitting in their labs or in their rooms or in their classrooms or in their hospitals, thinking about the next big question. But the problem is we know that there's a discovery to delivery disconnect. And that on average, and this is one of the focuses of implementation science, it takes about 9 years from an innovation that's published to actually translate into use in a clinical setting, which means we need to think of a new way of doing science. And one of those approaches is the community to clinic idea. It involves the idea that science really needs to be cyclical and not unidirectional. It is not experts telling communities what they need, but the other way around, with voices going back and forth and ideas going round and round. It is patient-centered. It means you have clinical trial navigators helping patients see what it is that they need and helping that be communicated to the clinical trialists who may not understand what it is that's really a barrier. It is not always money. Sometimes it's just having a listening ear and understanding what the concerns are. It needs to be community-based, and there needs to be a building of trustworthiness. People often say it's trust. That trust in patients, that's not patients' job, it's our job. We need to earn their trust. A great program that's been started at Penn, where I now work, that was been led by Carmen Guerra, who is our Associate Director for Community Engagement, has been really successful. And what it's focused on is really bringing the idea of clinical trials to the community in West Philadelphia. And it was a community outreach program that was conducted over the four years and presented at ASCO last year. And it worked with community-based programs in the African American community in West Philadelphia. And it included not only resources, but also messaging that really connected with that community and made them not only want to participate in clinical trials, but more importantly, want to come to Penn. People need to come to the places where clinical trials happen. And so again, you can't just go to places and say, come do clinical trials. You need to go to community and say, we want to care for you. When you show that you want to care for communities, they will also want to be a part of research. As Dr. Gary already mentioned, it's not that people are stupid. They know clinical trials are important, and they're also altruistic. Most patients are interested in bettering the world in which they live and helping the science that helps them. They need to be given the opportunity, they need to believe in the hope that they will be treated well and that it will actually make a difference for people who look like them. This study and this particular program by Dr. Guerra was so helpful because what it did was it increased significantly the number of Black patients who came to Abramson Cancer Center at Penn, and that in turn led to the numbers you see here in terms of increased participation in therapeutic trials, non-therapeutic interventional trials, and non-interventional trials. So again, getting patients through the door also gets them into clinical trials. We need to do both, not sequentially, but simultaneously. Finally, I want to bring up the fact that we just need to ask patients. Where is she? Not a doctor, but amazing. Valerie Worthy from Duke University is here. She is an amazing patient advocate, my good friend, and she knows that together, if you have someone who patients can connect to, and you bring up the idea of a clinical trial, they really want to participate. They want to help. They want to contribute to science. And at Duke, we had a great program called Just Ask that was started by Nadine Barrett, who, importantly, is a background in sociology, again, emphasizing the importance of social sciences and understanding the way in which you can do better medicine. And the Just Ask program is really an idea about how we can equip investigators to understand the potential psychosocial barriers to clinical trial engagement. And those psychosocial barriers, again, not putting it on the patient, putting it on the institutions. How do we do a better job at making patients want to be part of clinical trials? How do we make it a palatable option for them? That is something that burden lies with us and something that we need to be obligated to remedy. So in conclusion, redressing disparities in clinical trial participation requires, one, acknowledging and rectifying past and current wrongs in creation, dissemination, application of research. Congress recently passed the Henrietta Lacks Enhancing Cancer Research Act, which is meant to, again, encourage, again, the participation of minorities and women in clinical trials. Now, we've seen this done, as you know, in 1993. We'll see what this next act does. But I mention this again because people like to talk about Tuskegee, which, again, the head of the CDC mentioned in a tweet, Dr. Walensky, that was not wonderfully phrased, in which she said, we'd like to, quote unquote, honor the people who participated in the Tuskegee Syphilis Act. And I want to emphasize the fact that while well-intentioned, it completely failed to address the huge insult that was committed to those men, but also it is easy to hide behind Tuskegee as a remote problem that we're all still clinging to, when in fact, people don't participate in trials or come to their doctors because of how they're treated right now. I, as a black doctor, have been disrespected at my children's pediatrician's office, at my own OB-GYN office, at my own dentist's office. It is not about the past, it is about the present. And that is something you need to teach your colleagues about, something you need to reflect on yourself. What biases do we continue to bring to the healthcare space that prevent from equitable engagement and participation in trials? We need to recognize diversity not only across groups, but within them. Without that, we are not going to have the type of diverse messaging we need to get all kinds of people to the table. One example that a lot of people may not have appreciated prior to Kamala Harris's election as vice president is the power of the black sorority and fraternities in this country. The Divine Nine, or the National Panhellenic Council, has some of the most powerful black people in this country who have great buying power, who have great influence, who've accomplished a ton, and who could be great messengers and advocates for a lot of our scientific missions. Why aren't we engaging them? Why aren't we engaging people who have power, who it's not about money, again, it's about messaging. And we need to engage those individuals as partners in order for us to get to all kinds of people and improve participation across all socioeconomic statuses within different and racial ethnic groups. And then finally, our goal needs to be to come to patients and meet them where they're at. We need to provide opportunities for patients to hear about trials. And we need to have them tell us what they need, inviting them in ways that are sensitive and culturally humble. And then hopefully they can provide input to us so that we can then respond sensitively and with humility and with options that can really affect their ability to participate. With that, I would like to thank you all for your attention and for the opportunity to speak. And I'm very grateful to engage with you in this mission, which is so important to hopefully closing the gap in disparities in breast cancer in this country and in our planet. Thank you.